Hello and welcome back to the Gluten Free RN podcast. I'm Nadine Gross-Koyak, the Gluten Free RN, and today I am recording this episode in Austin, Texas. Today we're going to talk about blood and celiac disease. Is anemia the only symptom that you might see if you have celiac disease related to your blood, or is there more? Well, stay tuned because there is more. Hello and welcome back to the Gluten Free RN podcast. I'm Nadine Gross-Koyak, the Gluten Free RN. Today during episode 70, I'm going to talk all about the blood. Why the blood is so important, because of course it is, and how it shows up when you have celiac disease. The goal of this podcast is to make sure that you understand how celiac disease shows up in your blood or your patient's blood and how to recognize that because it's very important. So is anemia the only way that celiac disease or non-celiac gluten sensitivity shows up in your blood? Well, of course not. I've included an article from the Journal of Blood, 2007. It's entitled Hematologic Manifestations of Celiac Disease. In the abstract, and I'm just going to read this because it is fascinating. Celiac disease is a common systemic disorder that can have multiple hematologic manifestations. Patients with celiac disease may present to hematologists for evaluation of various hematological problems prior to receiving a diagnosis of celiac disease. Anemia secondary to malabsorption of iron, folic acid, and/or B12 is a common complication of celiac disease, and many patients have anemia at the time of diagnosis. Celiac disease may also be associated with thrombocytosis, thrombocytopenia, leukopenia, venous thromboembolism, hyposplenism, and vitamin A deficiency. Patients with celiac disease are at increased risk of being diagnosed with lymphoma, especially of the T cell type. The risk is highest for enteropathy type T cell lymphoma, or ETL, and B cell lymphoma of the gut. But extraintestinal lymphomas can also be seen. ETL is an aggressive disease with poor prognosis, but strict adherence to a gluten-free diet may prevent its occurrence. So here we have an article that's devoted to hematologic issues in celiac disease. And interestingly enough, a lot of people do present with anemia. As a redhead, and I laugh about this now, but it wasn't funny when I first got diagnosed, I always had anemia. My doctors always told me that I had anemia because I had red hair. Honestly, that's not based in any science. I had anemia because I had undiagnosed celiac disease for 40 years. But now that I'm on a gluten-free diet or my variation of a paleo diet, I am no longer anemic. One of the interesting things was that I had been taking iron tablets or iron capsules and iron everything, and I still could not absorb that iron because I had undiagnosed celiac disease and malabsorption. So I could take as much as I wanted. I could take it, but I wasn't absorbing it. Because of the damage to my intestines, the villus atrophy, there was no hope of absorbing anything that I took, whether it was in food or supplements, because I had undiagnosed celiac disease. Please keep in mind that if you're a man and you have anemia and you have osteoporosis, you have celiac disease until proven otherwise. So I'll say that again. If you know any men that have anemia, iron deficiency anemia, and osteoporosis, they have celiac disease until proven otherwise. So that's very important. And as I look back on my career as a nurse in the emergency department, I realized there were a lot of men that were misdiagnosed and mistreated because they had anemia and osteoporosis that was misdiagnosed, and they were never tested for celiac disease. Or I hope they were at this point, because obviously if you have chronic anemia and osteoporosis, your health outcome isn't going to be great. And unfortunately, people suffer with those things for many years without a correct diagnosis. So blood disorders are not rare in celiac disease, and it's not just iron deficiency anemia. It can be a B12 deficiency, which is pernicious anemia, which is interesting to know that according to this article that we mentioned earlier, while the main site of B12 absorption is in the distal ileum, where it is absorbed bound to intrinsic factor. A small portion is also absorbed passively along the entire bowel. Deficiency of B12 is common in celiac disease and frequently results in anemia. Malabsorption of B12 resulting in anemia has also been described in patients with DH, or dermatitis herpetiformis. The cause of the B12 deficiency in celiac disease is not known, but may include decreased gastric acid, hypochlorhydria, and achlorhydria. We can talk about that later. Bacterial overgrowth, autoimmune gastritis, decreased efficiency of mixing with transfer factors in the intestine, or perhaps subtle dysfunction of the distal small intestine. That right there is really important because a lot of people are on omeprazole or some type of H2 blocker or PPI, which is a proton pump inhibitor, which decreases their gastric acid. And unfortunately, many people are taking those medications for much longer than they're supposed to. Many people are taking those medications chronically or long-term, when in fact they're supposed to be taken for a few days at the longest. But many people, unfortunately, are on these medications for years. And believe it or not, it does impact your intestinal health and thereby your health long-term. The use of those medications also adds to bacterial overgrowth and gastritis because your stomach acid is supposed to be acidic. It's supposed to be a pH between 1 to 2, so very acidic, hydrochloric acid. It's not supposed to be more base or less acidic. So it's very important that that is corrected, and it can be corrected very simply through the use of lemon water or apple cider vinegar in water before meals, 10 to 15 minutes before meals. So it's very common that we have this decreased gastric acid when in fact we should have quite acidic stomach acid. And it's necessary to break down the food and to break down the fats and actually liquefy our food. So this is a little gross, but if you have undigested food particles when you are pooping, that's a problem. That is an indicator that your food is not getting liquefied in your stomach so that you can absorb things. So many of us that were diagnosed with celiac disease, and many of us at an older age, so I was 40 by the time I was diagnosed with celiac disease by accident. I was deficient in so many things, and I honestly don't know all of my deficiencies because my doctors and I did not know what to test for at the time. Now I know what to test for and the recommendations to make for people for a nutritional panel to find out what you're deficient in or what your baseline is. Because B12 is very important. And while on my blood test, my B12 was in the 300s and considered not deficient, it was still the very low end of a normal range. While that range is anywhere from 300 to 1200, mine was in the very low 300s, considered normal by my doctor, but very much not normal. So it is very important to get those baseline labs drawn for your blood work. And a CBC will cover a lot of the blood work, but do make sure that your doctor, in fact, orders a CBC with differential, because that differential will give you the breakdown of your red blood cells and give you an idea of how your immune system is working. So just a listing of some of the issues with blood that can be seen in celiac disease that's undiagnosed: thrombocytosis, thrombocytopenia, thrombocythemia, leukopenia, which is a lack of white blood cells or low white blood cell count, increased bleeding tendency, and that can include bruising or a vitamin K deficiency, which can lead to things like bleeding gums or nosebleeds or really heavy periods, IgA deficiency, splenic dysfunction, which can be seen in the RDWs. And I've done a whole podcasting episode on the spleen and celiac disease, so you can refer back to that if you haven't heard that episode yet. Lymphoma, especially the T-cell type. Celiac disease is a T-cell mediated immune response. So it's really important to look at anything that is T-cell mediated, especially if you are not looking at celiac disease initially. You should go back and look at any disease that is T-cell mediated in relation to celiac disease. leukemia, coagulopathy, again, that vitamin K deficiency, and the bruising. And the vitamin deficiencies that should be looked at in any of these hematology-related disorders are iron, folate, and please refer to anything that Dr. Lynch, who's a naturopathic doctor, writes or talks about related to folic acid versus folate, because folic acid is not necessarily a good thing to supplement our diets with. We should really be looking for dark leafy greens, red meat, and other ways to get the folate. B12 is very important for the formation and growth of red blood cells in bones, which, believe it or not, are where red blood cells are made, which is one of the reasons that men with anemia and osteoporosis are celiac disease until proven otherwise. The conclusion of this very interesting article from 2009 is that celiac disease is a frequent cause of hematologic disorders. Anemia and hyposplenism may be the most common hematologic complications. The anemia is most commonly secondary to iron deficiency, but deficiencies in folate, B12, and other micronutrients have been implicated as well. It seems reasonable to obtain a small bowel biopsy in all patients with iron deficiency anemia undergoing an upper endoscopy, regardless of endoscopic findings. The hyposplenism complicating celiac disease is rarely associated with serious infectious complications, but it is appropriate to immunize patients against encapsulated bacteria if there is evidence of splenic hypofunction. The risk of lymphoma associated with celiac disease has been overestimated in the past, but current estimates suggest that the relative risk is between 3 and 6. The risk is highest for T-cell lymphomas of the gastrointestinal tract, EATL, and other non-Hodgkin lymphomas of the GI tract. So while all blood disorders may not be related to celiac disease, it is very important to keep it in mind as a differential diagnosis for anyone that shows up with any type of anemia, splenic dysfunction, any embolisms, which include pulmonary embolisms, or DVTs, which are deep vein thrombosis, thrombocytopenia, and any coagulopathy disorders. Again, that vitamin K is so important, but it's a fat-soluble vitamin, much like vitamin D, so A, D, E, and K are fat-soluble vitamins, and it's very important to realize that we don't test for those other fat-soluble vitamins for the most part. We will test for vitamin D3, and if that's low, you pretty much can assume that all of your other fat-soluble vitamins are low also. So it's a good indicator. If you can get a practitioner to test for your vitamin K, especially if you have a bleeding disorder, or you have anything as simple as repeated or chronic nosebleeds or bleeding gums, it's very important to get those things tested. If your vitamin K is low, then a good idea would be to go on at least a gluten-free diet, if not a variation of a paleo diet that's just going to help your intestines heal and thereby help you absorb all of the things that are going to help you make red blood cells. And again, where are your red blood cells made? They're made in your long bones. So if you have osteoporosis or osteopenia or any bone disorder, there's a good chance that your red blood cells are going to suffer also. So it's all connected. Our bodies are all connected. So bone disorders are not separate from blood disorders at all. We have to look at everything in a connected way because, believe it or not, as human beings, our bodies are all connected. The thyroid has a lot to do with our absorption and our metabolism, and it's ground central for many things that are going on in our body, hormonally and every other way. So we really do need to make sure that all of this is getting addressed and addressed by our practitioners, regardless of what our practitioners do. So hematologists should be aware that people with these hematologic manifestations of celiac disease, that it's related potentially to celiac disease, and they need to test for it. They can't just say, well, you have thrombocytopenia and we're going to treat you for thrombocytopenia, or you're chronically anemic, so therefore we're going to give you iron. And if you don't absorb that iron, just take more of it. That's a very dangerous way to look at this. You really do have to keep in mind that the cause of the chronic anemia needs to be addressed. Why are our patients anemic? Why are they iron deficient anemia? Why are they not absorbing B12 from the food they're eating or from the supplements, leading to pernicious anemia? The very simple question of why always needs to be asked and then answered appropriately. And because so many people have never been tested for celiac disease, that's a great place to start. It really is crucial that people get tested for celiac disease very early on. Because as I mentioned earlier, I had anemia as a redhead, and I do highly recommend that all people with red hair, whether it's men with red hair in your beard only, or in your eyebrows, or anywhere in your body that red hair pops up, that you are potentially more at risk for celiac disease than other people with different genetics. And it doesn't exclude anybody, trust me. But if you have any propensity for growing red hair anywhere in your body, genetically you're potentially more at risk for celiac disease. So please keep that in mind. And let me just say again, that doesn't exclude anyone else. Celiac disease is a worldwide phenomenon. If you are a gene carrier for DQ2 and or DQ8, and you eat gluten or you are exposed to gluten in your diet, or even respiratorily, you think of Baker's asthma, then you are at risk for developing celiac disease, proper or non-celiac gluten sensitivity for those people that are not DQ2 and or DQ8 gene carriers. Let's go back just a second to talk about dermatitis herpetiformis, or DH. DH is frequently seen in anemia and splenic dysfunction. On that note, let me also tell you that DH, or dermatitis herpetiformis, is frequently misdiagnosed as many different things, such as eczema, contact dermatitis, dyshydrotic eczema, and many other diagnoses that it just goes on and on and on. I see people all the time and they come in and they say, I've had this rash for a long time. It was diagnosed as this. I was given steroid cream and it never really went away. Well, it's not going to if you keep eating gluten. And every skin disorder, for the most part, unless it's a topical exposure to something like poison oak or something else, all of those skin disorders start in your intestines. Your skin is a great mirror of whatever is going on internally. So these skin issues have to be dealt with from the inside out, not topically, unless it's an exposure to poison oak or some other type of topical pathogen or toxic substance. People with DH are at an increased risk for malignant lymphomas. So it's also a great reason to find out if what you have on your skin is really DH or dermatitis herpetiformis, because these people are at increased risk of malignant lymphoma, and that's blood cancer or cancer of the lymphatic system. Again, that's connected to your blood. So we do want to make sure that all of these things are addressed in an appropriate fashion so that people don't have to deal with these things and that we can actually prevent them from happening. Many of these things I talk about in every episode is about prevention of cancers, prevention of chronic illness, prevention of autoimmune diseases, to give people a chance to get old in a healthy way as opposed to dealing with all of these chronic, life-ending disorders. So in review of episode 70 of the Gluten Free RN podcast, where we're talking about blood and the hematologic manifestations of celiac disease, it really is important to read the articles that I've posted in the podcast notes, including this article entitled Hematologic Manifestations of Celiac Disease from the journal Blood, January 15th, 2007. Read through that article, and Dr. Joseph Murray is a author on that, along with Litzo and Helfendersum. And you can read through all these articles. Please do your own research. Please look at these things critically. Look at all these articles, read, get educated. So ideally, we're preventing these things from happening. We're preventing people from getting iron deficiency anemia, pernicious anemia, thrombocytopenia, and we're preventing DVTs and pulmonary embolism. Let's prevent these things because they are life-changing for people. Some people are put on medications such as Coumadin or blood thinners, and those are lifelong things. So we really do want to make sure that we're treating and diagnosing people correctly or recognizing celiac disease and having people get tested for it before we're doing these things that, potentially are damaging in themselves. Sometimes the treatment is worse than the disorder. I would also like to thank Heather for sending in a request for a future episode of the Gluten Free RN podcast. Heather is interested in a podcast in how celiac disease and non-celiac gluten sensitivity affects a woman's hormones and menstrual cycle, PMS, and all related information. This is a really great way to segue into that topic by talking about blood and women's health. So stay tuned for that very important episode. Thanks to Heather and everyone else that sends in any requests for information. And also, please leave a rating and a review on iTunes, Stitcher, or wherever you listen to the Gluten Free RN podcast. I'm Nadine Gross-Kowiak, the Gluten Free RN, and this has been episode 70 of the Gluten Free RN podcast. Thank you for joining me, where we got to talk about all of the relationships with celiac disease and blood. Fascinating, isn't it? Because we all have blood, and if you have undiagnosed celiac disease, there's a chance that you have anemia or some other blood disorder. And if we can connect those dots, because we're all connectologists, let's do it and get people recognized, tested, and treated appropriately. Thanks again for joining me, Nadine Gross-Kowiak, the Gluten Free RN, for episode 70. Stay tuned for more episodes. Bye.